Appreciate that. Thanks for sharing that, Doug. Alrighty, so this is our disclaimer letting you know that we do record these sessions and post them to our website. We actually edit out any of the case discussion portion, so any of that will be trimmed out, but we do keep this didactic portion. So if you have any concerns about being on that video, just let me know. And this is our CME disclosure, just letting you know that no presenters have any relevant disclosures for today's presentation.
Passing it over to Cassie.
Yeah, I'm just going to give a quick another little plug for Jill here and some background for all of you, because you'll see she's actually from Atlanta, Georgia, and we met her on a presentation that she was giving virtually that we found out about and got on. And clearly from this discussion, we have physical therapists in Nevada and California. They're all around. There's cancer exercise specialists like myself. But what really drew me to Jill's presentation was they're starting to do some Tele Rehab. And given that this whole survivorship program is about rural survivorship, I'm not aware of anyone in the Nevada area who is able to do the Tele Rehab as of yet to reach the rural communities. So it's one more resource that I wanted all of you to be aware of if you are seeing patients that are not from the urban area, and traveling in for appointments can be difficult on a long-term basis. So that's how Jill got here today with us, and to bring your attention to how rehab can help breast cancer survivors, and then also how she can help from a distance too, if needed.
Thanks, Cassie. And I have a 30-minute presentation, and it's about 20 to 12. So I am going to go very quickly because I think it's important that we ideally at least get to a few minutes of questions at the end. So forgive me for flying through. But the objectives today are really just to talk about common side effects of breast cancer treatment. That's where I'll go most quickly because we've had great talks on these throughout the last 3 months, really focusing today on the role of rehab and from the evidence point of view, barriers and access issues, and different kinds of approaches and models where we can start thinking about providing equitable access to rehab. So again, we're all aware of these, and I will skip through these, but there's a number of issues, including surgery, chemo, radiation, that contribute to some of the side effects of treatment that we see during and after breast cancer treatment. I do talk about them with my patients, and in any talks I give as side effects. It's very important that we're all on the same page. These are not complications. These are side effects. These are normal things that go along with this, and I think that's an important message to give to our patients. A lot of times physical therapists are the ones that are reminding patients, hey, when that latissimus flap contracts when you move your arm, that's normal. And we can really help and provide that information to people that sort of think something's wrong. So that's just one example. We are still unfortunately seeing lack of quality of recovery advice being an issue for patients. There's a lot of misinformation and myths out on the website, and people giving advice that may or may not really understand what the surgeries and side effects are, and that can actually decrease a woman's recovery. And I say women here, I will use that. We do see men at Turning Point as well, very similar treatment side effects. There's basically a pretty overwhelming research that patients report that they are not prepared for the physical and emotional side effects of breast cancer diagnosis and its treatment. So it can be quite shocking to the average person diagnosed when they start having some of these side effects. We all know, we've talked about these: pain, reduced mobility, and function of the upper extremity and trunk are common. Lymphedema, fatigue related to surgery, chemo and radiation, chemotherapy-related peripheral neuropathy are things that we see that impact function and quality of life. The cardiorespiratory and osteoporosis are issues, but just because of the time I have today, we're not going to address them. But certainly some of the things that we would be doing in rehab, including exercise and so on, would definitely be a part of that. So the physical therapy related to breast cancer is well documented. There's a number of older and newer studies that show that, you know, a significant majority of women undergoing particularly axillary lymph node dissection have issues early post-op. I think that's common sense. Katie Schmitz did a pretty landmark study that looked at 6 years post-surgery. That was the average that these women in this group were. And they found that 60% of women report one or more moderate or severe physical symptoms related to breast cancer treatment that actually would have been amenable to rehab intervention. Sometimes we don't see these people necessarily because they maybe finished their treatment. So they may not be seeing their oncology specialists at that time. And they may also just expect that they need to live with these things. And we know about the lymphedema risk as well. Axillary cording, we've talked about over the months. It's one of the things that we see in probably 70% of the women who've had a mastectomy or lumpectomies with axillary node dissection. It seems to be increased by the increased number of nodes removed. But as many of you know who've seen these patients, unless we actually ask them to sort of raise their hand and see it and feel it, it can be significantly painful and limiting, particularly in those early post-op days. And one of the interesting things, or post-op weeks, sorry, one of the interesting things is it's very amenable to treatment. So we can actually make a significant impact in that in the physical therapy realm. This is a patient who's 8 months post mastectomy and 2 months post radiation. This would be one of the first couple of times that I saw her, so she had not been referred to therapy. And you can really see the tightness in the surgical incision, decreased extensibility of the muscles around the shoulder, as well as more tight and kind of chronic axillary cording at that point. So these are some of the things that we're seeing in these patients. And you can see in this patient on the left side, she had pain, reduced mobility, axillary cording, function and dysfunction of the actual scapulohumeral rhythm and weakness around her scapula, which is common in our patients. And it's also been documented in the literature. So we know the lymphedema risk factors. I think I'll skip through that. I think we've talked about it several times. These are the kinds of things we're asking our patients so that we know who's at more significant risk. And as we know, the onset isn't typically immediate. The average is 6 months to 3 years post-treatment. So education early on is very important in terms of just because you don't have it at this point, each individual patient needs to know their specific and individual risk so that we can help monitor them and detect it early. And I'll talk a little bit more about that later. Chemotherapy-induced peripheral neuropathy is common in breast cancer, particularly, as you know, in the patients who've been treated with taxanes, Taxol, Taxotere. It's a symmetrical distal neuropathy. It's dose dependent. Sometimes chemo needs to be decreased if they have significant CIPN. We are also starting to see evidence in the physical therapy literature of balance issues because of reduced sensation and proprioception in the feet and ankles. So that's something where it's sort of an emerging science. And that's another thing that we're seeing and addressing in the physical therapy world. Cancer-related fatigue. This is, as we all know, and have talked about, a big impact on quality of life. Generally in the literature, about 48% of patients with cancer report it, and in the breast cancer literature, up to 100% of patients report fatigue that's significant enough to truly impact function and quality of life. This is some work from one of our PT colleagues, and they looked, and it's old, it's from 2008 or 9, but it's still actually, the literature is still being reported that's very similar to this, but this is a nice clean study that really looked at physical performance limitations and participation restrictions in cancer survivors in general, not just breast cancer. But if you look at the middle bar, any physical performance limitation, we would expect to see that in the sort of early post-cancer treatment patients, which are the blue bar, but they were really demonstrating that at five years plus, we're still seeing that over 50% of cancer patients have significant performance and participation restrictions. And I think that's really important. And that's not anyone's fault, but we do need to have rehab involved in order to reduce these numbers and address these issues. And we'll talk about why that doesn't always happen in a couple minutes. So in breast cancer patients, significant limitations in upper extremity functions have been linked to lower quality of life. You know, it's not just so what, they can't raise their arm fully. They are impacting women's lives. And we're finding that these activity limitations are more significant in patients with metastatic disease, in patients with other vulnerabilities. Definitely increased survivorship issues in, for example, Black breast cancer survivors. We're finding increase in side effects of breast cancer treatment and other issues like financial toxicity. So there is evidence to support that we can be effective in reducing these issues and in many cases even preventing them. And I'll talk briefly about that, but of course that could be a whole talk in itself, but that we can improve function and quality of life, and that by increasing physical activity and promoting exercise, we can actually decrease breast cancer recurrence. And we've known this for quite some time. This came out in 2008, the reduced breast cancer recurrence. But on a day-to-day basis, most of the patients that I see at Turning Point, and we see 400 to 500 breast cancer patients a year, very, very few of them know the relationship between reduced recurrence and exercise. And so that's an important thing that we can help provide and promote. So exercise in breast cancer, I discussed the recurrence, aerobic and resistance training actually has been shown to reduce fatigue. We know that we can decrease lymphedema risk, and when patients do have lymphedema, it actually decreases the severity of lymphedema, improves upper extremity function, strength, and range of motion, bone health, aerobic fitness, which has been shown to be reduced in breast cancer survivors, not just immediately post-treatment, but long-term as well in significant numbers. And there's more research that we need in the area of CIPN, but it's been an important, probably an important component in the management of CIPN as well. So we now have a lot of studies that support early upper limb range of motion exercise post breast cancer surgery. This is a Cochrane's systematic review by Margie McNeely out of Alberta, Canada. And basically all patients do better with supervised exercise post-surgery. And the only issue that we are very cautious of and aware of is if range of motion is started too early, less than 7 days post-op, we seem to increase the risk of seroma. So that's something we avoid, obviously. So we're typically thinking 2 to 3 weeks post-op is the ideal time to be starting progressive upper limb range of motion exercises. For women at risk of lymphedema, there's the evidence suggests that education, knowing their individual risk, prospective surveillance to manage early detection is really important. The earlier we detect lymphedema at those very, very mild phase, we can be much more effective. And Nicole Stout did some work in this area, and so that's an important part. Getting back to full range of motion earlier has actually been shown in a randomized controlled trial to actually reduce women's risk of lymphedema. So we want them full range of motion and back to normal function for that lymphedema risk. And then, excuse me, weight management, because we know that increased BMI is a risk factor for lymphedema. So when women do get lymphedema, and I'm just briefly going to mention it in passing, we do have evidence to support how we address lymphedema from a physical therapy lymphedema point of view. There's grade A best evidence put out by our practice guidelines for in our professional Academy of Oncology Physical Therapy that shows that education, aerobic and resistance exercise, and compression all have grade A evidence to support them. And so this is where we would start. We would start with someone with mild lymphedema with exercise and compression, which might be as simple as a sleeve and with or without a glove or a gauntlet. Some of the more complex, daily manual lymph drainage, kinesiotaping, laser have a little bit less evidence. And in our experience, what we're finding is if we start at that early phase, that's often what we need is compression, exercise education is keeping, excuse me, our women at a very low level of lymphedema. I'm going to skip through a couple of these because I know we want to get to some of the things about barriers to rehab. So in spite of what we know about the evidence to support rehab, there's a significant underuse of services. And I'm guessing that the physical therapists today would agree with that. We're certainly not even coming close. The gap, 60 to 90% of patients from lots of different research studies have been shown to have impairments that are amenable to rehab. But most patients in the United States and actually globally don't receive this kind of care. That's all cancers, but it's not different in the breast cancer world. And there's national standards that support breast cancer rehabilitation and inclusion of rehab for patients with cancer. And in spite of those, we're still not seeing that happen. And it's estimated, and it would be my experience, that probably less than 20% of cancer patients get referred for rehab. And there's other places we've looked at this with the American Cancer Society and developed, and I was involved in this project, we developed basically a model of care for breast cancer, which included pre-op rehab assessment, early post-op rehab assessment, ongoing surveillance so that we were catching these things early, catching fatigue early, lymphedema, decreased range of motion. And that was published in 2012, and it came out from the American Cancer Society. And we use this model of care at Turning Point, and we're finding it extremely effective, and that patients like it because they know that we will take care of them as these things crop up, and they know who to call. Education and exercise is fully built into the whole program. And if everyone was getting this, we wouldn't have people sort of left out, those 80% of people that never have a touch point. Not everyone needs rehab, but by this kind of a model, we can ensure that at least there's a touch point for breast cancer patients at some point. And so some of the barriers, lack of established relationships between rehab and oncology professionals. And one of the analogies that I use to sort of describe what happens here is that if you had knee surgery, you would expect, a layperson would expect that you're going to have swelling and decreased range of motion and stiffness and pain, but you'd also expect to be referred for physical therapy. And so if your orthopedic surgeon didn't refer you, the average patient would ask for their physical therapy referral. It wouldn't be seen as a complication. It would just be a normal part of their recovery. And that in the oncology world has not existed. And we've been working very hard for probably 20 years now to develop that. Lack of availability of specialized care is really a critical piece. We don't have enough physical therapists trained to do this. Environments where there's a big group gym may not be an appropriate environment for cancer patients to be exercising and recovering. And the last parts are self-advocacy. Often patients don't want to bother their doctors about an issue related to their shoulder, or their fingers have some numbness and tingling, because our doctors save our lives, and we don't want to sound like we're complaining about minor issues. So we also, are trying to normalize this. Back to the knee surgery. You've got pain and swelling, it's okay, but we can take care of that. There's significant racial disparity in breast cancer survivorship, and it's an important issue that I hate to go through quickly, but we know that Black breast cancer patients do not do as well as patients who are white. And we know this even when everything else in their treatment is controlled for. There is some really good research that has come out that has talked about this, and we're also concerned about COVID-19 because there's increasing racial disparity related to COVID-19 that may actually amplify the issue that we're seeing in breast cancer survivorship. So this is an important topic. Bridging the gap. So models of care, and it's a couple minutes too. I'm looking at you, Troy, to cut me off. Should I just zip through to a couple of the models that we're trying to implement to do some outreach?
Yeah, please, I think go ahead and finish up here, and then we'll have just maybe a minute or two for questions.
Okay. So Turning Point is a nonprofit, and I founded it, and I'm now the program director at Turning Point. And it's a community-based model. It is also a nonprofit. It allows us to provide services and programs not covered by health insurance. It provides financial assistance to reduce that barrier to care. It's also an independent clinic, so we're seeing patients from all the different hospital systems in Atlanta. And what we have found, we started in 2003. It's interesting because we have an outpouring of community support. We have fundraisers, we have donors. Many of our former patients are donors because they realize the importance of physical therapy and rehab in their recovery. So it's just an interesting sort of side note that patients really do want this and they will support this. We offer integrated programs and services that include PT, both in person and now with COVID, Tele Rehab, lymphedema, exercise, massage therapy, nutrition, counseling, special programs for patients with metastatic breast cancer who are definitely an underserved population as well, and then education, particularly related to survivorship issues and providing patients with evidence-based information, which can be very difficult to come by online. These are just some patient outcomes, improvement in shoulder mobility and function, both at admission and discharge from our program. And these are clinically significant differences that we're seeing. don't have a control group to show you, but we do measure this and we track it. So community-based oncology rehab offers some accessibility. We can adapt to new evidence. We can integrate different kinds of rehab care so that we can address all patients' needs. And we have grown based on patient feedback and observed needs that our patients have. We do use the prospective surveillance model so that patients do know they can come back to us at any time. 3 years out, if they notice some swelling, they will be fully educated and know who to call and when. COVID-19 brought significant challenges to us as well as everyone else on today's call and in the United States. Our patient surgeries were postponed, and our patients were facing life challenges on multiple fronts, going through breast cancer, as you know, homeschooling their children, facing loss of jobs. So we had to pivot our care delivery pretty quickly so that we could take care of the patients we already had and new patients referred to us. And so this is what we developed, was a sort of a 6-point plan to take care of our patients during COVID. We added pre-op appointments where we had done those in the past, but focused on them more because we had patients waiting for surgery, so we could help them during that time, and pivoted everything else to go virtually, including Tele Rehab, which I'll talk about in just a minute. So during COVID, at least in the first few months, all of our patients were seen in Tele Rehab. We started April 1st. And we were amazed by how successful we could be in taking a patient right from initial post-op visit all the way through chemo and radiation. And the patient on the right is someone that I saw 2 to 3 weeks post-op initially, and we got her range of motion back, and I have been following her through her treatment. So it just something that was fascinating, that we could pivot what is typically a very hands-on kind of care to Tele Rehab. So since we initiated Tele Rehab and our survivorship education events went virtual, live virtual, so we actually have a physical therapist or a dietitian or whoever the professional is on a Zoom webinar. So patients can ask questions. These aren't just taped events. We've had a really significant increase in how many people are checking in. We've gone from sort of a live event monthly of 13, 14, 15 people to having 300 and 400 people who are breast cancer survivors receiving these education events. So it's been interesting, and we will definitely be continuing with this. It also, though, opened a whole area where we can do outreach. And so we now have a group of physical therapists, and includes 2 breast cancer surgeons, or 2 breast surgeons. And we are including in the United States plus 5 other countries. And we are working to develop a standard clinical assessment and management plan, or a SCAMP, for breast cancer rehab. And we're using an echo-inspired model to train local community physical therapists, and so that we can do outreach and partnerships with communities so that we can increase the care to unserved rural communities, other communities that are typically unserved or underserved. Black communities in Atlanta, Detroit, and Louisiana are part of our pilot projects. Native American communities are not getting any of this kind of care at all. And we actually are partnering with a group in northern Michigan who, it's interesting, all the patients are traveling for up to 4 to 5 hours for their cancer treatment, and there's no physical therapists that are doing any kind of cancer care in northern Michigan. So by pivoting to Tele Rehab, we're hopefully able to reach more patients. It doesn't necessarily substitute completely for in-person care, but when a patient going through breast cancer would not receive any treatment at all, we can significantly impact their quality of life and their recovery through a Tele Rehab model and education on a virtual platform. This is some outreach that we're doing to healthcare providers across the United States. We had our first forum in October, and we have 3 more coming up to work on enacting change to increase, to reduce racial disparity in breast cancer survivorship. This is more of a pitch than anything. It's a big area of need, and if anyone's interested, my contact information is available both on the website, and I can provide it at the end. But we're looking for people to engage with us. We have a lot of people trying to move this forward. And I think my conclusion are that in my experience, rehab and exercise are effective. And community-based oncology rehab models may be an effective way to bridging and closing this gap. Tele Rehab, we're working on that, and we're doing outreach with that, and we'll be reporting on it as well. I want to thank you for this. I'm sorry it was so quick running through it, but hopefully that's been helpful. Some references here, and there's a lot more that I'm happy to provide. And there's my email address. I'm happy to talk to anyone about any of these topics at any point. Thank you.
Appreciate it. Thank you so much, Jill. I see Michelle wrote in that she's a licensed PT in Nevada and California and providing telehealth PT as well as exercise class for our local community via Zoom. Michelle, are you still on? Would you want to talk about your program a little bit as well?
Yes, great to see you again, Jill, by the way. Yeah, ironically, I did a poster presentation in February at our annual meeting on a project I did using telehealth for exercise for rural cancer patients that live up to 3 hours from my center, and then COVID hit. So I continue to do exercise classes via Zoom, and I also am licensed in both states, able to do PT via telehealth as well. So I look forward to connecting with more of you and seeing how I can help these projects and help our patients.
Excellent. Thanks, Michelle. Yeah, if folks have questions about that or maybe want to get their patients participating with you, is just reaching out to you through your email there the best way?
Yes, and I posted it there. I'll post it again. But yeah, I'd love to connect with anyone.
All right, thank you so much for sharing that. Any questions for Jill here today?
Jill, great talk. And for both you and Michelle, thank you for all that you do, especially with the telemedicine part of it. Certainly as surgeons, particularly for the reconstructive part of it, what we encounter a lot of times with patients is treatment fatigue. They've had all these treatments with chemo, with radiation and things like that. You can offer them physical therapy, other treatments, but a lot of times they are just so tired of having daily or multiple times a week having to go to a therapy. But I think telemedicine is certainly going to help a lot in regards to compliance. Also your work in the racial disparities and healthcare disparities in general is huge. It's something that we're trying to emphasize with what we're doing, particularly here in Nevada, for the socioeconomic disparities, because we have certainly a lot of rural areas that can't get a lot of these treatments. So telemedicine may be one of the ways to help that. Although, unfortunately, a lot of times, the technology, and we've seen this in our telemedicine consultations, is very limited in the different racial and socioeconomic underserved. So it ends up being also a challenge, and sometimes it even widens the disparity because we end up being able to service more people, but usually not the people that need it the most. So any thoughts in regards to, what else we can do to help fix those socioeconomic and racial disparities, rural disparities for patients that maybe don't have fast enough internet to be able to stream, a live rehab or something like that?
I have a thought about that, which just came to me because I was listening to someone talk about public libraries. Wouldn't it be cool if we could somehow collaborate with a local library to, have that be an access point for people who don't have, great internet or, are just using their phone?
It's also a great opportunity to partner with the rural clinics. So especially, if it's a PT consult where the patient needs to have their shirt off or something, if they can have access to an exam room and a computer just for those. So it's a great networking opportunity for rural clinics. And then I like the idea of the libraries. I've even heard of some people partnering with local banks, and they would have a little room for a telemedicine appointment. Again, not one where, visual privacy was really needed, but there's been some banks that have been willing to give up an office for a telemedicine appointment.
Yeah, so I was just going to say, when I did my little study, that was the biggest barrier, was people's either not having a computer or not having internet. There was plenty of people that needed the exercise and wanted to exercise, but that was a huge barrier in the rural communities. And someone suggested going to the governor to expand internet, in these rural areas. But I know there's some PT projects dealing with total joints where they actually give the patients a computer and a hotspot and just give it to them. And that is something that, we might look at down the road. And or we were also looking at meeting at a community center where they had internet. So it's just being creative and out of the box.
I was going to say the same thing. I think it's being creative, out of the box. We just applied for a grant actually to do a pilot project like this, but with a model of, you really do need to partner with the community, both to make whatever program you're doing culturally appropriate as well as sustainable. That's a really important part of anything that we would be doing. We just applied for a grant to do rehab outreach for breast cancer survivors in Iraq. And one of the barriers there is that we may be able to achieve or overcome is that women don't go to appointments on their own. And so they always need a driver. And so one of the things that we did as part of a grant that we applied for is we need to pay for internet access, and we may need to actually pay for devices. And some of the things like iPads and that kind of thing are not outrageously expensive. And so we're figuring that out as we go, but it depends on the community. In the Michigan community that with Native Americans, they do have community clinics that are usually fairly close that have internet access. So we were doing some of the things that you were talking about, Michelle, is really trying to partner with that, but it really needs to be looked at, and it's definitely a barrier. Rural Georgia, we have the same issues in terms of access. Haven't gone to the governor yet, but he's pretty busy right now in Georgia. But it is an issue. But the problem with something like increasing access like that, we're looking at years down the road, which is an important thing to start with. But the more immediate solution may be to try and partner and use community centers. And I love the idea of banks. If we could figure out how to make it private. It really does need to be private if we're doing what we're doing. We're looking at incision sites and range of motion. And you saw my patient on her Tele Rehab appointment. She had her top off, and keeping kids out of the room. We really have to instruct our patients. They don't just hop on a call. We have a pretty good list of things to think about before we do our first appointment in terms of privacy and so on. So it's something that's evolving, and we're getting better at it, but we're still learning.
Great, thanks. I think one of the other things that you mentioned in your lecture that's extremely important for this community is again, seeing these patients with the community, because as you said, a lot of people individually feel like, oh, I don't want to bother my doctors, I don't want to bother my treatment people and things like that. And I think having more survivorship things like this, so they can meet with other women that are going through the same things and have had benefits either from the rehab side, the reconstructive side, lymphedema side, whatever, so that they know that there are options, that there are things that they can do, because oftentimes they don't ask, they don't want to bother anybody. They think, oh, I should just be thankful that I survived cancer and things like that. And we don't really think about a lot of these things, unless we're with the survivorship people that are talking about all their different concerns, and then they see that, hey, I'm not the only one, and there are things that can be done to help.
Absolutely.
Thanks for your questions, Dr. Baynose. Any other questions from the group? And I realize we are a little over time here today. Appreciate you all sticking with us. I sent out some information through the chat box if you do need to take off and you want to claim your CME or CEU credits. So just go to that evaluation link. And then once you submit the evaluation, they'll be redirected. Punch in that 4-digit code and you can get your transcript with this session already on it for today. But any other questions for Jill or the rest of the team?
That was really great. And of course, it gave me lots of new ideas. So Michelle, we have to talk.
Yes, thank you so much. This has given all of us a lot to think about. And I think, yeah, Michelle, Cassie, and I will definitely want to pick your brain more too, because everything that Jill's talked about has been something that we've been wanting to, have everyone here and really work on together and figure out what we can do to overcome some of these barriers for people. So I think this is a fantastic starting point. And, we have a lot of people on the call that are passionate about this. So I can see that this will go further, which is exciting. So thank you all.
I'm going to throw out one more thing. I don't know if I think Doug was having microphone issues, but Doug, the physical therapist who's on the call, he a couple years ago started a lymphedema support group here in the Reno area. They've taken a break from meeting with COVID and stuff, but he does have that, and he's been sending out great information during the pandemic. So if anybody's interested in a lymphedema support group, and it doesn't necessarily have to be lymphedema from cancer treatments. He does do that. So giving him a little plug, and it looks like he put his phone number in the chat box. But it's a very unique group. There's not many of those around. And I had the privilege of going a couple times, and it's a really great thing he started.
Excellent. Thanks for bringing that up, Cassie, and mentioning the great work Doug's doing. Looks like he sent out a number where he can be contacted as well as his email there. So thank you.